Good morning, doctors. I welcome you all to this webinar of Implantology. This is a fourth webinar that we are conducting right now as a part of webinar series, mega webinar series that we have promised you. Now, today's topic is Implantology, and we will be talking about the basics of Implantology. With us, we have Dr. Udatta Kher, who is a renowned speaker on this topic and authority on this topic actually. So, talking about Dr. Udatta Kher, he has done his masters in oral surgery. He has been practicing in Mumbai since 1995, and he has specialized in implant dentistry. He is a passionate, dedicated doctor and a passionate teacher. He is a director of Impart Education, which is an academy to train dentists in the field of implant dentistry. So I think today's session would be a gist of his experience since 1995, and I'm sure it will be very interesting and enlightening session that we are going to have. I would like to take this opportunity to share with you a news that our beloved brand Mega CV has recently entered into a 100 crore club. So thank you very much for your patronage and your support. Do continue your support, and we would like to do this kind of programs in future. So I will not take much of your time, and I will request Dr. Udatta Kher to kindly start his session. Please, sir. Thank you.
Thank you very much, Pankaj, for the invitation to conduct this webinar, and thanks to Aristo Pharma for facilitating all the logistics. Good morning, friends. Today I am going to be speaking to you about prosthetic solutions and treatment planning for the fully edentulous patients. A little bit of a background. This is where I work. This is my workplace in Kher. This is where I've been practicing dentistry. My professional life is divided into about maybe 60% of my time is devoted towards clinical dentistry, and the remaining 40% of my time is devoted towards teaching through the academy called Impart Education, wherein we are training clinicians in the field of implant dentistry and full mouth rehabilitations. So this is how I divide all my professional life. Coming to today's lecture topic, like I said, I'm going to be speaking and focusing mainly on fully edentulous patients. We'll talk about treatment planning for the fully edentulous patients. I'll discuss about the different prosthetic options that are available for the edentulous patient. Some tips on choosing the right type of a prosthesis for that particular patient. I'll also share with you some cases and discuss the clinical steps that are required for the fabrication of that prosthesis. As we know, life expectancy throughout the world has increased, and so has it in India. So over the years we have seen that people are living much longer, and as people live longer, the need for them to have a complete set of teeth has become essential for their basic nutrition. So as people age and they lose teeth, there is a need now for a third dentition, which is now man-made completely, and this third dentition is what we provide patients with. So when a person has lost all the teeth and now we need to reconstruct and give the patient a full complement of teeth, it is a bit like constructing a building. So wherein you need to have a foundation and then you have a superstructure over it. Similar to that, when we are doing rehabilitating patients who are fully edentulous, the first thing that we need to do is create a foundation, and this foundation is created with the help of implants. And over that is going to be the prosthesis, which is going to be the superstructure, which will help the patient to function efficiently. Now, as you know, for every building construction, you need a team of people to work. The architect who is going to be designing the basic structure, and a set of contractors who will be able to execute the plan that has been made by the architect. Similar to that, when we are practicing implant dentistry, it is seldom a one-man job, and it usually requires a team effort. And in the team you would have the surgeon, you will need the periodontist, you would have the prosthetic dentist, a general dentist, and of course the laboratory. So with the help of a team approach, one is able to satisfy the increasing demands of treating these fully edentulous patients. So I would like to acknowledge this wonderful team of mine in practice who are all the time with me when I am doing rehabilitations of these edentulous patients. So typically this is the workflow that we follow when we are doing treating patients. It starts off with the initial planning, then you have the surgical phase of treatment where the implants are placed, and then you have a phase where there is a provisional, where during the interim restoration phase for the patient, which is then followed by the final restoration for that patient. Now there are two ways in which implant dentistry gets practiced, particularly in our country. You see the image on the left is where implants have been just randomly placed without any specific kind of planning, and the image on the right where there is a specific plan in mind. And when you look at these two images, you can well imagine that the clinicians who are not putting too much thought into planning and ending up with situations like you see on the left are the ones who will always have a lot of trouble during the prosthetic phase of the treatment and will always fall short of a perfect outcome. Whereas when there is a thought process and a plan behind the treatment, you will see that the images on the right where the implants have been placed in a very methodical manner in a place where they ought to be. And you will see that clinicians who take the time and the effort to plan cases so that the implants can be placed in this methodical way will usually land up finding that they are able to end up the cases very well to meet the expectations of that patient. There are three phases of treatment. The preliminary phase which has the diagnosis, the treatment planning, the fabrication of a stent which will enable the surgeon to place the implants. Then you have the intermediate phase wherein the patient is going to be on an interim restoration, a provisional restoration till the implants osseointegrate. And then you have the final phase of the treatment which would entail making impressions, taking jaw relations, taking trials for the patients, and then in the end giving the patient a satisfactory prosthesis. When it comes to full arch implant prosthetics, these are the frequently asked questions, and these questions would be, typically how many implants are required for a fully edentulous patient, whether the prosthesis has to be fixed or whether it can be an overdenture, whether it has to be a screw retained restoration or a cement retained restoration, which of the two is the better option. Then whether it should be in acrylic, whether it should be in ceramic, or whether the material of choice is zirconia, and whether the prosthesis in the lab should be casted or whether it has to be milled. Now these are the typically framed questions, and somewhere during my presentation I will address all these questions. But apart from this, if there are any other questions that cross your mind, please do not hesitate to put up your questions during the course of this presentation, so that towards the end of the presentation I will try and answer as many questions that I possibly can. The first step in after one sees a fully edentulous patient is a decision making that one has to do, and in this decision there are two things that are always going to remain constant. The one constant aspect is the bone that the patient has, the patient is presented with, into which the implantologist is going to place the implants. And the second constant position is the position of the patient's incisors. Now, irrespective of what prosthesis we are going to give this patient, the incisal edge position or the position of the central incisors is a non-negotiable position, and that cannot be altered irrespective of where the patient's bone is and irrespective of where the implants are going to be placed. So when you have these two constant positions, there is a decision that the clinician has to do, is what are we going to do about the in-between space over here? Is there going to be a surgical option for this, or is there going to be a restorative option? Now when we are talking about surgical option, what we are looking at, we are actually looking at augmenting bone, we are looking at regenerating bone and getting the bone to a level where the implantologist can then place the implants, and then the restorative dentist can end up the case by restoring the tooth in its most ideal position. But we all know that managing this kind of a surgical procedure, wherein we are going to augment the bone after the patient has had teeth extractions and bone loss, to augment the bone back to its original level, is a very unpredictable procedure and something that will require multiple surgeries, and very often we don't land up with the desired outcomes when we are trying to augment that kind of bone. So more often than not, when we are treating fully edentulous patients, we are actually looking at managing this whole problem by doing some good restorative work. So the entire transition in over here in between, this zone between the tooth positions and the implant, is managed very creatively with the help of some really nice restorative options provided by the laboratory. So the point I want to make over here is for fully edentulous situations, as far as possible, we are looking at more graftless solutions, or solutions where we need to do a minimum amount of grafting as against doing extensive amount of grafting to achieve the desired results. Now coming to the pertinent question of how many implants are required for treating a fully edentulous patient. Now this is again dependent on the specific patient type and the requirement of that particular patient. Now assuming that this patient has been planned for a overdenture prosthesis, so typically in a mandibular overdenture we are looking at about 2 to about 4 implants to rehabilitate a patient. So you're looking at a 2 implant for a patient who has a fairly good alveolar ridge, and you're looking at only providing retention of the denture to the patient. And when there is going to be more amount of resorption, when the patient presents with a more resorbed alveolar ridge, be it the maxilla or the mandible, we are looking at about 4 implants and then connecting them with the help of a bar to be able to support a restoration. Now when it comes to treating patients who are fully edentulous with a fixed option as against an overdenture, so when you are looking at fixed options, there is a formula that we use for deciding on the number of implants, and that would typically depend on the zones that are present where the bone is available. Now if we were to divide the zones that are available into 3 zones, so the zone 1 is the incisors and the canines, the zone 2 are the 2 premolars, and the zone 3 are the 3 molars. Now assuming that the patients present with different amount of bone in these zones, we decide on the number of implants that have to be placed. Now let's look at the best case scenario, that the patient presents to you with bone in all the zones. So you have bone in zone 1, zone 2 and zone 3, which means that this patient actually has fairly abundant amount of bone. In this situation, the best treatment option would be to place about 6 to 8 implants which are all going to be straight, parallel to each other, and then give the patient a fully fixed restoration. Something which looks like this, where the implants are placed across the arch, and you can see a good distribution of implants that has taken place. This is the type of prosthesis that you would want to give the patient. Let's look at the second scenario now, where the patient has lost bone in the molar regions on both sides. So now the patient has bone only in zone 1 and zone 2, which is the incisors, canines and the premolars. Now when the patient presents to us with this scenario, there are a couple of options. One option, which is a very popular option, is what we typically call as the all-on-4 option, wherein we place 2 tilted implants and 2 straight implants. Now this is typically done when the patient is an elderly patient. So patient who is you could call as a geriatric patient, where you want to keep a minimum amount of surgical trauma to this patient. You restrict the amount of implants to 4. So you have 2 tilted and 2 straight implants, and give the patient a fully fixed restoration. If a patient who is much younger, and these days this is quite common, we see a lot of patients who have lost all their teeth at a much younger age. When such a patient presents to us with bone in zone 1 and zone 2, this is where we look at the all-on-6 option, wherein you have 2 tilted implants and 4 straight implants in the anterior region, and give the patient a fully fixed restoration. This kind of a treatment option does not exist at all. So to place 4 straight implants in the canines incisor area and give a patient a fully fixed option is unscientific. So it does not exist anywhere in literature. At best, you can give the patient a removable option over 4 implants like this with the help of a bar reconstruction, or maybe some kind of a telescopic design. Let's look at a case where there is extreme resorption now, and now this patient has presented with bone only in the incisors and canines, which means premolar onwards there is no bone left at all for us to rehabilitate. Now, when a patient presents with this situation, what are we looking at? We are looking at either augmenting bone in the posterior parts of the mouth with the help of bone augmentation procedures like sinus lift procedures or maybe grafting procedures to increase the volume of bone and then placing implants, or then a procedure wherein we are using zygomatic bone now for supporting our implants and placing zygomatic implants to provide support for the final prosthesis. So, this is a situation which again in my opinion should be reserved only to extreme situations where the rehabilitation of the alveolar bone is no longer possible with any amount of grafting, and then we are looking at doing rehabilitation by using the zygomatic bone for supporting the prosthesis. So, what I discussed until now was mostly the maxilla and the treatment planning for maxilla. When it comes to the mandible can present with two different scenarios. The scenario number one that you see on the left is a patient who has presented with adequate amount of bone in the incisors and up to the premolar areas. So, let us assume that between the two mental foramen the patient has adequate amount of bone, and beyond the mental foramen on both sides there has been a lot of resorption due to which placement of implants there would be difficult because of the proximity to the inferior alveolar nerve. In this kind of a situation, one of the options is to place about 5 to 6 implants, 5 to 6 straight implants between the two mental foramen and give the patient a fully fixed restoration. This is a very popular graftless solution for the mandible for patients of almost all age groups. You see the picture on the right side wherein there is abundant amount of bone, and when patients present to us with adequate amount of bone from molar to molar, it would be incorrect to just place implants in the anterior part of the mandible, and in this situation it's a nicer treatment plan to actually divide the implants, or rather space the implants out from molar on one side to the molar on the other side, and then give the patient a nice good fixed restoration. Now, this kind of a fixed restoration could either be in segments, it could be in small parts like small bridges, whereas the first option where we are placing the implants between the mental foramen always is a one piece prosthesis. So, that kind of prosthesis is never divided, it is a one full arch prosthesis which is always screw retained over the implants. So, to sum it up, in the mandible we are looking at about 5 to 6 implants. Those implants could be between the mental foramen or then spread out from molar to molar. So, this is typically a scenario where 6 implants are placed in between the mental foramen for a patient who had no bone in the posteriors. Another scenario wherein you have extreme amount of resorption, again a geriatric patient, the same all-on-4 option that we discussed in the maxilla is also possible in the mandible, where 2 tilted implants are placed in the premolar sides and 2 straight implants in the incisor areas, and a screw retained fixed prosthesis is delivered to the patient. Now, what are the different type of prosthesis that we provide our patients? This is a very old classification by Misch, and we still follow this pretty much, very popular now. Is the fixed prosthesis get divided into 3 categories. You have the Fp1 prosthesis, where as you see in this image, you have only the crowns that are replaced, so no part of the alveolar ridge has been replaced. You have adequate amount of bone, and typically like a crown and bridge scenario is the Fp1 prosthesis. In the Fp2 prosthesis, you will see that a small part of the root is also replaced along with the crown form, and the Fp3 prosthesis is where there is more amount of resorption that has taken place. So, a part of the alveolar ridge is also replaced along with the dentition. So, these are the 3 fixed options. When it comes to the removable options, you have the removable prosthesis 4 or the RP4, which is a completely implant supported restoration. Now, this restoration is done with the help of implants that are placed and a bar that is constructed over those implants, over which a prosthesis is then fitted. Now, this is a removable denture, it is an overdenture which the patient has to remove every night. The RP5 is typically indicated for patients who otherwise have a fairly good alveolar ridge, but their only complaint is that the lower denture is loose. And in these situations, we keep the treatment plan quite simple. Just place 2 implants in the anterior part of the mandible and provide the patient with an overdenture, which will then snap over these two abutments. So these are the pretty much all the different prosthetic options. These are again 2 images. The image on top is a tissue supported overdenture, wherein you see the denture looks like a conventional denture, but it gets retained with the help of the 2 implants and the abutments over it. What you see below is a maxillary overdenture. In the maxilla, we seldom keep implants isolated. The implants in the maxilla are always linked to each other with the help of a bar reconstruction like this. And over this is a denture which need not have the palate. It can be a palateless denture like this, which will go and fit onto this bar and provide the patient a really good retention and a lot of stability for the prosthesis. Types of fixed restorations get further classified into 2 types. So when you're looking at fixed restorations, you have what is known as the cement retained restoration and the screw retained restoration. The cement retained restoration is a bit like crown and bridge, wherein you have the abutment and the prosthesis, which is like your bridges, which get cemented on top of those abutments. Needless to say, once you fix it with the help of some kind of a luting cement, these are non-retrievable, which means that the patient or the dentist cannot take this prosthesis out very easily. The second option, which is the screw retained option, wherein the prosthesis is fixed on top of the implants with the help of screws. Now the good thing about this is that as far as the patient is concerned, the patient cannot take this prosthesis out, but as a dentist, you can within a few minutes unscrew these the screws and take the whole prosthesis out, so that this prosthesis can be maintained in future. So when it comes to doing fixed restorations, as far as possible, we look at doing screw retained restorations when we are doing rehabilitations for a fully edentulous patient. So the screw retained restorations is always the first choice when we are looking at doing full arch restorations for the fully edentulous patient. Though of course in certain select situations the cement retained restoration still has a place in full arch implant prosthodontics. This is just an example of a cemented restoration. As you can see, these are abutments over the 7 implants, and that's the restoration that gets cemented over it. But as you can well appreciate that removing this restoration is not going to be a very easy task. As against that, you see this is a screw retained restoration over 6 implants. You see the screw access holes on the palatal side, which are very easily accessible to the dentist whenever he or she chooses to unscrew this prosthesis and take it out for the sake of repairs or maybe for the sake of maintenance. There is a third design which has become popular in the last few years, which is a combination bridge, which takes the advantage of a screw retained restoration as well as the cementable option. So in this option, you have a framework which is typically made of titanium, which is milled. It has a part of the alveolus that gets replaced, and that is usually pink porcelain or pink composite, and that gets screw retained over the implants, and over that are either individual crowns or bridges which are cemented over this prosthesis. So here you have the advantage of having a cemented restoration which will provide very good aesthetics and help in hiding all the screw holes. And you have the option of retrievability, wherein you have a base which is screw retained and which can be taken off. So this type of a combination bridge again is an option for the fully edentulous patient. Now coming to the screw retained restorations, there are different materials in which these restorations can be fabricated. And if we were to classify the type of materials that are used for fabrication of these prostheses, the entire classification would be into 2, one is the framework materials used and one is the layering material used. So any prosthesis that we do will first have a basic framework which is going to provide rigidity, and then you'll have a layering material which will provide the actual tooth form. So as far as the framework is concerned, the frameworks can either be casted or the frameworks can be milled in the laboratory. The casting is typically done in non-precious alloys. When it comes to milling the prosthesis, the milling procedure can either be accomplished using titanium, it can be done using cobalt chromium, or it can be used done with the help of some modern materials like zirconia or PEEK, which are more tooth colored materials that are become quite popular in the last decade or so. Coming to the layering materials that are used are typically acrylic, it could be composite resin, or harder materials like ceramic can be used as a layer over these framework materials. So if you were to really look at any of the prostheses that are given to fully edentulous patients, it would basically be a combination between one layering material and the underlying framework material. So it's always going to be a combination of these two. Needless to say, there is some compatibility issues between a framework material and layering material, and that is something that as clinicians we need to understand that certain framework materials can be used only with certain layering materials, and in certain areas one needs to make a certain compromise or maybe tweak the treatment plan to accommodate one framework material and one type of a layering material. But the whole question here is who decides? Who decides on what should be used? Is it the patient who decides? Is it the implant dentist who decides? Or is it the lab technician who decides? So obviously the patient is the one who wants the prosthesis. Patient is the one who pays for the prosthesis. So based on the patient's ability to be able to afford the treatment, the patient obviously has a say in the matter. The lab technician is there to help the clinician on the various treatment options and the various material selection choices. But finally it is the implantologist who is going to make the final decision on what is the right type of prosthesis that has to be chosen. So these are the factors that have to be considered. Number one is the age of the patient's functional requirements, the patient's aesthetic requirements, the condition of the opposing dentition, whether it's a natural dentition or whether it is a denture in the opposing dentition. The financial conditions consideration obviously will come into picture when you choose the right type of prosthesis. Coming to choosing the right type of material, there is one factor that kind of decides, that will help us in deciding what is the best material to be used for that particular patient. And the decision on what is the best material would typically depend on the amount of alveolar bone loss that has occurred. And depending upon the amount of resorption that has occurred, we can classify that into mild, moderate or severe. So you can see that in the first scenario there is mild amount of resorption, then there is moderate and there is a severe amount of resorption. So if you are looking at a minimum resorption wherein the interarch space, which means from the incisal edge to the bone, you have an interarch distance of about 10 to 12 millimeters, we are typically looking at a porcelain fused to metal or a porcelain fused to zirconia and giving the patient a typically Fp1 type of a prosthesis. In a second scenario where there has been a little bit more of resorption, you have an interarch distance of about 12 to 15 millimeters from the incisal edge to the platform of the implant. Again over here the choice of material would be a hard material like PFM, like metal ceramics or ceramic layered over zirconia, and give the patient Fp2 type of a prosthesis. In a situation where the resorption is much more, where you are looking at restoring part of the alveolar ridge, here we are looking at lighter materials. So wherein you are needing to fill in a large space here, you are looking at giving the patient a hybrid denture, which would be metal acrylic or maybe a combination of PEEK framework and some composite resin over it. The last scenario where there is extreme resorption, wherein the interarch distance on one arch is around 18 millimeters or more, these kind of cases are actually almost contraindicated for anything fixed, and you're really looking at giving the patient an overdenture option like a RP4 or RP5 kind of a restoration. So when it comes to diagnosing the edentulous patient, we have to look at the patient's lip positions. So you see the amount of lip support that are required. So you look at an edentulous patient like this and see that when you look at a patient like this kind of a patient is almost contraindicated for a fixed restoration, because this patient requires lip support and a lip support cannot be provided with the help of a fixed restoration, the patient would need to be given some kind of a removable denture with a flange. Against that, see this patient who has adequate amount of bone because of which the lip dynamics are good. This is a suitable patient for a fixed restoration. So whenever we are planning a case for a fully edentulous patient, when a patient presents to you with a fully edentulous situations, one of the first steps that one has to do even before you take a radiograph for a patient is to make a trial denture. A trial denture is essential for us to understand the final aesthetic outcome of that case. Also to understand whether this patient requires any lip support to provide in the prosthesis. And also once you mount the trial denture, you also have an understanding of the amount of facial cantilever that you are going to have on the prosthesis and whether a need for a flange exists in that particular prosthetic design or not. An example of this is in this particular case. As you can see, that's the position of the lower teeth, that is a proposed position for the upper teeth, and the bone condition that the patient presents would mean that the implants get placed far more palatally and far more apically, and in a situation like this it would be impossible to give this patient any kind of a fixed restoration and give the patient some lip support. So for a patient like this who need this kind of a flange on a denture, we are looking at doing over dentures and providing the patient with a good aesthetic outcome by giving a nice support to the upper lip. So the point here I am making is that before we jump into any surgery, there are a couple of things that one has to look at. One is making a trial denture for the patient and then looking at the cone beam CT scans to correlate the amount of bone that the patient has presented vis-a-vis the final prosthesis that we plan to deliver. So with this background, I would now want to go ahead and showcase 3 cases of patients who are fully edentulous and have presented, and these are day-to-day cases that all of us see in practice. Let's look at the first case. This is a 2-implant overdenture case. This is the lady who presented, who was wearing a denture but was very unsatisfied with the lower denture. We have this in practice. We have patients who are denture wearers who do not have a problem with the upper denture but have a problem with the lower denture because of the looseness in the denture. And the treatment for these kind of patients is fairly simple. We can provide the patients with a 2-implant overdenture. So let's look at this case, and this is the surgical phase of the treatment. This is typically the incision that is made. A full thickness mucoperiosteal flap is raised. After that, the unevenness of the bone is taken care of by doing a little bit of crestotomy. We mark the midline position, and from the midline position, the ideal locations for the 2 implants would be approximately 10 millimeters apart. So we mark those positions, and the osteotomy is done to place the 2 implants. As you see over here, the implants are being placed in the locations which are 10 millimeters apart from the midline. They are as parallel as you can get them, then widening the osteotomy and placing the 2 implants, followed by the healing abutments, and then the closure. So a case like this, the patient continues to wear the existing denture, comes back to us after about 2 months. A second stage surgery is done to place the healing abutments, and then we begin the prosthetic phase. So in the prosthetic phase, to give the final dentures to the patients, we first take a preliminary impression in alginate or impression compound. A cast is made. On that a customized tray is designed, and this is the lower customized tray. These are the impression posts. To snap impression posts are used in this particular case. That is the custom tray. Border molding is done the way we would do for a conventional denture, and then we pick up the impression posts in a polyether material. The stone casts are then poured. This is the master cast over which the laboratory will fabricate the final restoration. You take the interocclusal records, the jaw relation is recorded, then the teeth positions are decided, a tooth setting trial is done for the patient, and once this is approved by the patient and the patient is satisfied with the way this looks, we go ahead and prepare the final dentures. So as you see, this is the upper and lower dentures for the patient. That's the upper conventional denture, which is not implant supported, whereas the lower denture, which is implant supported. Here, as you can see, the two locations for the implants, and these are the corresponding attachments inside the denture which the lab is incorporated. These are the two ball abutments which are going to support that denture. The ball abutments are removed from the model and placed and torqued over the two implants, and then the lower denture is delivered over it, which snaps in place and provides the patient with adequate amount of retention. The upper denture is a conventional denture, the lower denture is an overdenture. As you can see, we have provided the patient with a good aesthetic outcome, providing good lip support and good function, taking care of the patient's basic needs, that is providing good retention to the lower denture. So cases like this are very I would say very basic level of treatment that we can provide all our edentulous patients, and someone who is starting out their journey into implant dentistry, I would encourage you to look at these kind of cases in your practice and try and satisfy the needs of the patients with these kind of cases. The next couple of cases are a little more advanced. These are cases wherein we have to provide the patient with a fixed restoration, and of course this requires a slightly higher degree of experience and training, but something that we see very often in practice, and if you are in a practice which has a team, you should be able to fulfill these kind of requirements. Again, another lady, she's also 75-year-old, but she presented with a situation where she was losing her existing teeth. Her underlying bone condition was fairly good. The plan was to retain all her lower teeth and extract all her upper teeth because they were all failing. Some were mobile, some were broken down. This is the surgical phase where we extract all the teeth. We placed all the implants into the extraction socket. So this is like a immediate extraction and implant placement scenario. Those are all the implants that are placed. We continued giving the patient a removable denture as an interim restoration for 4 months. After 4 months, the patient comes back. We do the second stage procedure of uncovering the implants, and this is how it looks after all the soft tissue has healed around it. Now we are on to the prosthetic phase. This is again the impression procedure. The impression is done. After that, the laboratory sends you, a jig which you try in the mouth to verify the accuracy of your impression. Next step is the laboratory will provide you with a teeth setting trial, wherein you see now that the patient does not require any flange for lip support. So this particular trial is done without a labial flange. Just the tooth positions are the ones that we are looking at over here. So a teeth setting trial is done once the clinician and the patient is satisfied with the tooth positions in the patient's mouth. We then go ahead and do the next trial, which is a Bisque trial, which will get us close to the finishing stages. Then take the shade selection is done, looking at the patient's age. We decide that we are going to do some characterization for this patient and provide the patient with a restoration which is more age appropriate, something that somebody who is in the late 70s is going to be able to carry off quite well. So this is the prosthesis. This, as you can see, is a Fp2 type of prosthesis. It is a metal ceramic restoration. It is screw retained. It is extremely strong and sturdy. Very easy to fix and extremely easy to remove whenever we need to for retrieval. So that's the screw retained PFM prosthesis, porcelain fused to metal. So the underlying metal is cobalt chromium, which is milled, and ceramic is layered over it. Those are the screw access channels which have been closed with the help of composite resin. That's how it looks on the radiograph. As you can see, all the implants are very well osseointegrated, and you have a well fitted prosthesis over it. This is how it looks in occlusion. This is how it looks on the patient's smile. And we were able to rehabilitate this 76-year-old lady who also has a fairly active social life and who did not want a removable denture and wanted a fixed option. And we were able to provide this patient with a reasonably good outcome. So this is how we started, and this is how we ended up. Coming to the third and last case, and like I said in the beginning of my presentation, these days we also have to look at rehabilitating much younger patients. We have patients who are much younger. Now this particular patient was actually only I'm sorry, there is some interruption in. Can you just get me the laptop? My apologies for this little technical glitch, but let us continue. So this is the young patient who presented to us. She is a very young lady. She is in her mid 40s, but unfortunately she was losing all her teeth. This is the surgical phase of the treatment, wherein we go ahead and place 7 implants in the maxilla, and we place about 6 implants in the mandible. And then during the healing phase, again we give the patient an immediate removable denture. We allow the implants to osseointegrate. The patient comes back to us after about 6 months when the implants are all well integrated. After this, we start off with the prosthetic phase. We take the impressions for the patient. This is the lower arch impression. Then this is the upper arch impression. After that, these are the master casts that have been made. The next step again is to take the jaw relation record. So the patient's jaw relation is recorded. That is then mounted on a semi-adjustable articulator. Next step is again to verify that the impression is correct. The laboratory will send us a jig trial. So we make the jigs, we connect it onto the implants and make sure that there is a good passive fit of this trial over the implants. Once this is done, we then take the first trial for the patient by setting the teeth. Now you see in this particular situation for this young patient, it just does not look very aesthetic. So we want to modify this trial by reducing the amount of vertical dimension. Once that trial is approved, we then give the patient a fully fixed acrylic provisional. Now we don't go to the final restoration in these kind of situations because we want the patient to try out the prosthesis. So this is a heat cured acrylic fixed provisional that we have providing this patient. Now this provisional gets screw retained into the patient's mouth, and with the help of this, now the patient is able to test drive this prosthesis, which means the patient goes home, tries it out, functions with it, takes feedbacks from the family, whether the appearance is good, whether the function is good, whether the patient is comfortable with this type of a prosthesis. And only after the patient gives us the green signal, we go ahead and then start making the final restoration for this patient. So the work again goes to the laboratory, and then the laboratory now makes the final restoration. So these are the steps, these are the references that we will send the laboratory. During the fabrication of the prosthesis, the patient again has the temporary restorations in the mouth. The laboratory will then make the final restorations. Again over here, this is upper and lower metal ceramic restoration, which is screw retained, as you can see in this image. All the screw access holes coming from the palatal and the occlusal surfaces. That is the upper and that is the lower prosthesis. That is how the tissue looks, and that is how the upper restoration looks after it's fixed over the implants. That is the mandibular implants, and that is the mandibular restoration. This is how it looks eventually when it's fixed into the mouth. The occlusion is adjusted, good uniform contacts are established throughout the arch. Those are the occlusal views of the two upper and lower fixed restorations. That is how it looks on the radiograph. Again, you see, nice good bone all around the implants. Those are the smile views of this patient. As you can see, this is a young patient. She is only in her 40s, but we were able to provide this patient with a very, very satisfactory end result, which is functional, which is aesthetic and easy to manage. That's how it looks on her face. This is the satisfied patient. So to sum it all now, this is my concluding slide. This is the take-home message for all of you who are already doing implant prosthetics for fully edentulous, or those of you who are aspiring to do this in the future. One rule is that the prosthetic plan should always be made before implants are placed. Implants should be placed according to that prosthetic plan and not very randomly. The choice of prosthesis depends entirely on the amount of resorption of the alveolar ridge and amount of restorative space that exists. So with this, I again thank all of you for attending this webinar, and I thank Aristo Pharma for this opportunity. My email ID is here for any future correspondence with me. Feel free to get in touch with me. And I also look forward to answering some of the questions that some of you may have asked during this webinar. Thank you very much.
Thank you very much, sir, for this enlightening session. I hope everyone has enjoyed it. We have received most of the questions related to implant, and we have shortlisted few of them. Sir will go through the questions, and they will just answer the questions which are relevant to this session. But in case you want to watch this webinar again, so you can do this with the same link, and this link will be up for next 1 month. So all you have to do is go back to the link, click on it. If you are already registered, just put in your email ID and you can watch the recorded version of this webinar. And for questions, sir, whenever you are ready.
Okay, I'm ready, so I think we can go ahead.
Thank you, sir.
So I have a list of questions here, and I will try and go through each one of them and try and do justice to them. So the first question is how to manage patients with insufficient ridges. True, this is always going to be a dilemma. Again, like I say, when the patient presents to us with different amount of bone available to us, we are left with two choices. One is either we augment the arches, do a bone augmentation procedure, increase the volume by doing surgical procedures and then place the implants. Or at times when the patient is more elderly. So this is typically what I do in practice is when the patient is far more elderly, I minimize the amount of grafting for those patients. I make use of the available bone between the premolar sites or between the mental foramen in the lower region, and give the patient a fully fixed restoration. Whenever a patient is much younger, I prefer to do like bilateral sinus lifts, do augmentation in the mandible, increase the amount of bone, and then give the patient a fully fixed restoration over more number of implants. So the next question is how many implants do we need in fully edentulous patients for both arches? So I think I answered that question during the webinar. So again, just to sum it up, the number of implants is dependent more on the age of the patient, not just the available bone or let's say the patient's ability to afford the number of implants. So younger patients, more number of implants. I typically go to 6 to 8 implants in each arch. Geriatric patients, I'm happy to do 4 implants and a fully fixed restoration. And patients who are in their 60s and who lost their teeth in that age, who still have a fairly good life expectancy, I would like to give them about 6 implants in each arch. At what torque can we immediately give final prosthesis for premolar tooth? I kind of didn't get this question right. If I understand it correctly, I think this is not a question pertaining to a fully edentulous situation. It is specific to only a premolar tooth. My advice to the person who is asking this question is if it is for a single tooth premolar, my advice to you is unless the tooth is in the aesthetic zone like the first premolar, refrain from doing any kind of immediate loading of a single tooth in the non-aesthetic zone, especially where the patient is going to use that for function, use that to chew on. It would be a high risk. Even if you get very high torque values on the day of implant placement, that particular implant is at a risk of a failure later on. So premolar tooth, single tooth, aesthetic zone, first premolar, I would give interim restoration which is out of occlusion. To take this question to a fully edentulous patient, if the patient is fully edentulous and you're placing maybe 6 implants or 4 implants, and you get good high torque values in excess of 40 Newton centimeters, one of the plans could be to give the patient an immediately loaded restoration. Now this restoration can get fabricated on the day of the implant placement when you are using screw retained option, or a laboratory fabricated restoration can be fabricated within 3 days and placed over the implants, provided you have a good distribution of implants, provided you have good size implants, and provided you have good bone over there to support those implants and get fairly good torque values. So there is one question which is framed like this: planning for all on 6 or all on 4. Some details about GBR, flapless implant placements, basal implants in brief, zygomatic implants in brief, how to establish. I think this is this is like a 1 week course, not even 1 day. The amount of questions that have been asked over here. But yeah, I think I've answered my questions typically during the webinar itself. The indications for all on 4 versus all on 6. All on 4 typically for more geriatric patients, all on 6 for younger patients who do not have a bone in the posterior parts of the mouth. You are looking at a typical all on 6 restoration. Zygomatic implants, again I would restrict it only for more elderly patients where you've kind of given up on the alveolar ridge because there is no bone left there, and you're looking at the zygomatic bone now to support a restoration. What is the most commonly used framework and layering material nowadays? So this is a very pertinent question. This again would depend, like I discussed during the lecture, would depend a lot on the amount of restorative space that we have. So depending on the amount of alveolar resorption that has taken place, we would decide on the choice of material. So if the alveolar space, if the alveolar resorption is minimal and the restorative space is say anywhere between 10 millimeters to around 14-15 millimeters, you're really looking at a very sturdy prosthesis. So you don't want to use a soft material there. You want to use something which can withstand occlusal loads without fracturing easily. So you're looking at a metal framework, and then you're looking at ceramic teeth on top. So when you're looking at metal framework and you're looking at ceramic teeth on top, the typical combination would be cobalt chromium framework and then ceramic layered over it. This is my most favored combination for a fully edentulous patient who has bone anywhere between 10 to around 15 millimeters. When a patient has restorative space, which is from the incisal edge to the prosthetic platform in one arch, anywhere between 15 to 18 millimeters, I then use a hybrid restoration. The hybrid restoration could be a titanium bar with acrylic teeth over it, or it could be a PEEK framework with composite resin teeth over it. And like I said, if it is beyond 18 millimeters, I do not encourage the use of a fixed restoration. An overdenture is a better option. I think again there is a question about choosing courses, how to go about choosing a course, and how to go about choosing an implant system for the practice. So again, something that I keep getting this question, and there can't be one right answer for this. When it comes to choosing a course, needless to say, you want to attend a course from clinicians with a lot of experience in teaching, a lot of experience in handling different types of prosthetic solutions for edentulous patients, and enough of surgical experience in doing all kinds of various implant related surgical procedures. Courses again should not be the typical company driven weekend courses which will only provide you biased information. Courses should be more which are more unbiased, which do not necessarily have any companies supporting them with free implants, etc., wherein the academies are typically dependent on the fees that are collected from the participant, wherein that's when you will really truly get the right kind of unbiased information. Regarding choosing the implant system, these days it is very, very confusing. There are very, very low cost implant systems, and then you have the very good branded implant systems. The choice of implant system would typically depend on your practice and your patient's affordability. So if you are in a region where the patient's affordability is a big issue, then you are looking at slightly lower cost implants. The problem with lower cost implants typically would be that they are perhaps do not have the same brand value that some of the good time tested and researched implants have. And that is an information that I think we owe it to our patients, that if we are using implants which are low cost, which do not have enough of scientific data backing it, we should inform the patients that these are implants, but they have the limitations as far as track record goes, and that by choosing an implant system which has been in the market for a long period of time, which has been researched well, which has a lot of scientific publications in its name, is something that one should choose in their practices. I understand that this comes at a cost, but this is something that I think we owe our patients. There is another question about the disadvantages of cortical implants and basal implants. Again, this is a question that gets asked to me very frequently. There is this option of using the basal implants and cortical implants. The biggest disadvantage of that option is the limited number of prosthetic options that exist for those kind of implants. Like I said during my webinar, one of the main features of a prosthesis should be retrievability, and that retrievability means that from the time you deliver this to the patient, you would need to maintain this prosthesis till the rest of the patient's life, and that could be 10 years, 15 years, 20 years. With the conventional implants, the two-piece implants, most of the times we are looking at doing screw retain restorations, which every few years can be taken off, repaired easily and placed back in, can be replaced if required without really putting the patient through too much trouble. Whenever you have a cemented option, wherein the prosthesis gets cemented over those implants, one option is to cement it with temporary cements. But we know that in practice, those temporary cements get loose, and every few months the patient comes back to you with the prosthesis in the hand, which can get very annoying to the patient and very uncomfortable to the clinician. To avoid that, clinicians are then tempted to use a luting cement and cement those prostheses. Now, when you do a full arch cemented restoration, one of the biggest nightmares in practice is that if you ever need to take that prosthesis off for maintaining any of the implants, or if there is any chipping or breakages of that prosthesis and you need to send it back to the lab, it can be one of your most disastrous days in practice if you were to take out that full arch cemented restoration. So because the basal cortical implants do not still provide sufficient options of screw retained restorations, and their main focus is towards cemented restorations, in my practice I stay away from that treatment option. The next question is, this is a very specific question. While doing graftless solutions, do you necessarily expose the anterior wall of the maxilla? This is very specific to tilted implants. Now, when we are doing tilted implants and we are placing the implants which start from the second premolar site in the maxilla and angulated at 30 degrees, and the end of the implant is somewhere in the region of the canine root, this usually needs to bypass the anterior wall of the maxillary sinus. If you are into doing a freehand surgery where you are not using a guided surgical stent, in that case it would be important for you to understand where the anterior wall of the maxilla is. So in that situation, it is prudent to expose the anterior wall of the maxilla through a very small window opening. If not, the better way would be to use a surgical stent wherein the angulation and the inclination of the implant can be managed very well through the help of the stent, and where you can avoid opening the anterior maxilla and straight away go and place the implant. I'll perhaps take one last question now. This is again something more pertaining to practice management. This is from somebody in Delhi. The question is, how do you establish yourself as an oral implantologist in a competitive market like Delhi? How do you increase the number of implant patients in your clinic? So again, this is a lot to do with your practice, the way you have projected your practice. I can't really give you too many messages on this about how you can get more number of patients to do implants. I'll just tell you, I can only speak for my practice. Typically in my practice, an implant based treatment for missing teeth is always like the first choice, or maybe at times the only choice that is given to the patients. The way to increase the awareness in your practice is to keep talking to patients about implants being the nicest and the best way to replace missing teeth, and that all the other options, though are viable options, are not necessarily the best options for replacing missing teeth. So when you keep talking to patients about this, you kind of generate a practice wherein the patients are also understand that that implant based treatment is the best solution for them. And over a period of time, the increased awareness of this subject worldwide and more so in India has definitely increased the number of patients who are opting for implant based treatments. So with this, I think I wish all of you my best wishes for your practices. And I do hope that you continue to train yourself and you continue to practice implant dentistry at the highest international standards, and overall raise the bar of implant dentistry in this country. And I thank Aristo Pharma and Pankaj once again for this opportunity. Thank you.
Thank you very much, sir. I would like to extend our gratitude to Dr. Udatta Kher for getting time out from his busy schedule and to deliver a fantastic lecture on implantology. Again, I would like to remind you that this session would be up on the net for 1 month. So if you want to watch it again, you can go and watch it again. Don't worry. Okay? And our next session, we would shortly give you the topic and the speaker's details. Till then, thank you very much for joining us. Thanks a lot. Thank you.